Welcome to This Week in Radiology. This week, we're covering 10 notable papers spanning artificial intelligence in the reading room and the reporting pipeline, breast imaging from density scoring to biopsy markers, and advances in neuro and musculoskeletal imaging hardware and stroke care. Let's dive in. We start with artificial intelligence, where the interesting question has shifted from whether algorithms can detect disease to what happens when you actually plug them into a working department. In European Radiology, a prospective alternating month study switched a commercial mammography algorithm on and off, month by month, across more than 4,500 examinations read by 4 radiologists. During the assisted months, the cancer detection rate roughly doubled, from about 11.5 to about 22 per thousand examinations, and reading time did not budge at all, sitting at around 65 seconds either way. That is reassuring for anyone worried that decision support adds friction. The important nuance is where the false positive cost landed. For screening examinations, the abnormal interpretation rate was statistically unchanged at around 9%. For diagnostic examinations, though, abnormal interpretations rose from about 12 to nearly 19%, a meaningful jump in recalls and further workup in a population that already has a clinical problem. The practical message is that the same tool behaves differently depending on the indication, and diagnostic mammography deserves more caution than screening. Staying in European radiology and in breast screening, a second paper examined automated volumetric density scoring from a commercial artificial intelligence model in 200,000 examinations from BreastScreen Norway. Cancer detection performance was strong overall, but it fell steadily as breasts got denser. The area under the curve dropped from about 0.96 in the fattiest category to about 0.86 in the densest. 2 findings should give pause to anyone planning density-based risk-stratified screening. First, the proportion of women labeled as extremely dense differed by mammography vendor, roughly 3% with one manufacturer versus nearly 7% with the other. Second, at the individual breast level, close to 1 in 5 examinations assigned the right and left breast to different density categories. So the same woman could be classified differently depending on which machine she attended and whether you score the examination or the breast. Read alongside the reading time study. The theme is consistent. These tools work, but their behavior is context dependent, and local validation is not optional. Artificial intelligence also showed up this week in the unglamorous but high-yield space of reporting. In the Journal of the American College of Radiology, a group implemented a vendor-agnostic optical character recognition pipeline that reads numbers straight off bone density images and drafts complete reports. Across 4 sites, report creation time fell from about 3.5 minutes to under a minute at the academic sites, and from about 1.5 minutes to under 40 seconds in the community. The turnaround figures are the striking part. Community site turnaround dropped from roughly 134 hours to 42 hours, about a 4-day improvement. Accuracy was preserved and in fact marginally better than the original human reports, and completeness at community sites went from 45% to 100%. This is a reminder that some of the largest available gains are in structured, numeric, template-driven reporting rather than in diagnosis itself. Our second theme is breast intervention and the tissue imaging mismatch problem. In the European Journal of Radiology, a single-center series of 334 patients used ultrasound-guided vacuum-assisted excision with a 9-gauge device to work up lesions where the imaging appearance and the core needle histology disagreed. After excision, about 70% of lesions were benign, 1 in 5 were B3 lesions, and just over 9% were upgraded to malignancy. Delayed false negatives were about 1%, specificity and positive predictive value were 100%, and there were no major complications. BI-RADS category, morphology, margins, and orientation all predicted upgrade. The practice implication is that for discordant lesions, a percutaneous vacuum excision can resolve the discordance in most women and spare them a diagnostic operation, provided you accept a residual upgrade rate around 1 in 10 and follow the rest. Complementing that, Radiographics offers a review of biopsy marker selection, the clips we place and largely stop thinking about. It traces markers from simple metal to multi-material devices that now serve cross-modality correlation, surgical planning, and radiation targeting, with good long-term safety and cost-effectiveness through fewer re-excisions. The contemporary problems are marker migration, allergic reactions to metallic or embedding components, and poor ultrasound visibility, addressed by non-metallic designs, careful placement timing, migration prevention technique, and exploiting the Doppler twinkling artifact to find the clip on ultrasound. Our third theme is hardware and technique, where two papers ask whether new detectors and new software actually change what we see. In the American Journal of Neuroradiology, a pragmatic paired comparison put clinical photon counting CT against conventional energy integrating CT in 194 patients, contributing 270 matched examinations, read blinded, and at least 4 weeks apart. In the main non-contrast brain cohort of 225 pairs, photon counting scored higher on overall image quality, and pathology conspicuity favored it in essentially every pair, 224 of 225. Gray to white matter contrast to noise roughly doubled. Dose-normalized contrast to noise rose even more, and median dose fell about 22%, from about 49 to 38 milligray. Artifact scores were no different. The authors are appropriately candid that scanner generation, vendor, protocol, and reconstruction were all unmatched, so this is a real-world system comparison rather than proof that the detector alone is responsible. Pointing in a similar direction from the software side, the European Journal of Radiology reports 33 knee examinations in 26 patients scanned at both 0.55 Tesla and 3 Tesla, with deep learning denoising applied to the low-field data. Unprocessed 0.55 Tesla imaging achieved sensitivity and accuracy around 0.83. After denoising, sensitivity rose to 0.97 and accuracy to 0.98, with excellent agreement against 3 Tesla. Image quality and reader confidence improved with denoising, but still remained below 3 Tesla. In a small retrospective single-center cohort, that is encouraging for low-field musculoskeletal imaging in resource-limited or point-of-care settings, without yet displacing high-field magnets. Our final theme is neurologic disease, and here the notable results are the negative ones. In the American Journal of Neuroradiology, investigators asked whether baseline amyloid burden on PET, expressed as a centiloid score, predicts amyloid-related imaging abnormalities in patients on lecanemab. Across 41 patients with these abnormalities and 72 controls, and after adjusting for age, sex, APOE epsilon 4 status, and baseline microbleeds, baseline centiloid was not associated with the complication overall, nor with the hemorrhagic or edematous subtypes, nor with time to onset. An exploratory regional analysis did find modestly higher baseline uptake in the specific regions that later developed edema compared with mirrored contralateral regions, which is hypothesis-generating only. So global amyloid quantification should not currently be used to triage which patients are safe to treat. Also in the same journal, a propensity match comparison of tenecteplase versus alteplase before thrombectomy in patients aged 80 and older analyzed 278 matched pairs. Good functional outcome at 90 days was similar, 48 versus 43.5%, with confidence intervals crossing 1, as were early reperfusion, symptomatic hemorrhage, and 90-day mortality at 30% in both. Complete neurological recovery at 24 hours was more frequent with tenecteplase, but the authors show that signal was confined to a single scale value, left no trace at 90 days, and is vulnerable to unmeasured confounding, since drug was completely confounded with center. The honest conclusion is equivalence, and randomized data in the very elderly are still needed. Rounding out the neuro section, radiographics provides a review of lacunar stroke syndromes, which make up about a quarter of all strokes, covering the 5 classic syndromes, atypical presentations, and the mimics that trip readers up when infarcts are too small to see confidently. If you only have time for one paper this week, make it the alternating month mammography study in European Radiology. It is one of the few prospective, in-workflow tests of artificial intelligence assistance that measures both the benefit and the cost, and its indication-specific finding should shape how your department deploys these tools. Here are the key takeaways from This Week in Radiology. Artificial intelligence assistance in routine mammography raised cancer detection without slowing readers down, but increased abnormal interpretations in diagnostic examinations only. Deploy it deliberately by indication. Automated density scoring varies by mammography vendor and between the two breasts of the same woman, so validate locally before building risk-stratified screening on it. Some of the biggest operational wins from artificial intelligence are in structured numeric reporting, where automated bone density drafting cut community turnaround by about 4 days while improving completeness. Ultrasound-guided vacuum-assisted excision resolves imaging histology discordance in most patients and can spare surgery with an upgrade rate around 1 in 10. Photon-counting CT delivered better brain image quality and conspicuity at roughly a fifth lower dose in real-world use. And deep learning denoising brought low-field knee MRI close to 3 Tesla accuracy. And 2 negative results matter. Baseline amyloid centiloid does not predict amyloid-related imaging abnormalities on lecanemab, and tenecteplase and alteplase performed comparably before thrombectomy in patients over 80. That's your roundup for This Week in Radiology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And if you have a paper you have been meaning to read, upload the PDF or paste any link at audioscholar.cc. We will turn it into audio like this one in any of 31 languages. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.